Hello, everyone. Welcome to Mobile ODT's latest webinar on forensic non-fatal strangulation examinations. My name is Sarah Veiling. I'm the Sales Marketing Manager at Mobile ODT, but I happen to have a background in forensic social work, and I'll be moderating today's webinar. My apologies for the delay. We had a little bit of a technical difficulty, but if you have any other issues going forward, you can try to contact me by chat. Before we get started, a bit of information about today's webinar format. We'll have about 30 to 40 minutes for our presentation, followed by 15 minutes for our Q&A session. If there are any technical issues, like I said, please contact me via the chat and I'll do my best to assist. At the end of the webinar, we'll spend a few minutes letting you know about the EVA system for forensic documentation and a few offers from the Academy of Forensic Nursing. Without further ado, I would like to introduce our esteemed guest, Diana Fogno. This is the second time that Diana has graciously agreed to present for Mobile ODT. She's the current president of the Academy of Forensic Nursing and board director of EVA. Diana has made numerous presentations to the sexual assault response teams across the country, as well as the scientific community assemblies such as the American Academy of Science. She is dedicated to providing trainings across the country to assist teams in the development of staff on topics using curriculums and educational standards on various topics in forensic nursing. You can take it away, Diana.
All right, well, thanks. Glad to be with you all, everyone, and thanks for attending today. I will also tell you that I still work per diem as a forensic nurse examiner at an advocacy agency here in Georgia. So that I truly love because it's that direct patient care. So today is just going to be a little bird's eye view of strangulation, hopefully enough to pique your interest. And I think we had some polling questions, did we, Sarah? Did you already do that?
Launch the first poll.
So there's a couple questions here, guys. If you just give it an answer, that will help us understand your experience.
Okay, I'll just give a little, I can see that we've got about 50–60% of the vote. So I'll give it a couple more seconds. And my apologies, the second question was supposed to come out later, but it's good for us to see where you're at now. Okay, I'm going to close the poll.
Okay.
Okay, so 77% of you have worked on cases involving strangulation. And 76% of you said it takes 4.5 pounds of pressure in order to occlude the carotid artery, but we'll get to that answer later on in the webinar.
Okay, thank you, Sarah. That helps me a little bit too. Well, we did put some objectives today together for this. We were going to talk about some visible signs and symptoms, and just to understand a little bit about what the physics or the pressure is that's required in this area, and then talk about some best practices for improving treatment and care to our patients who have been strangled. And I do have a case example that we'll go over at the end. So next slide. The key points to be covered. What we're really going to drill down here too is we're going to talk about potential complications and medical treatment. Of course, that's always a big thing. The equipment you might need in order to put this piece of forensics together for your team, the forms you might need, photograph storage and release, follow-up, the budget and funding, and then medical support. and this includes your MDs in your emergency rooms that are really key to the treatment for this type of violence. Next slide.
Great.
All right, so there's some myths to strangulation, and typically these are the barriers that you're going to face with the emergency room staff, with people in general, that strangulation is choking, strangulation is not serious, and strangulation, typically, if you've been strangled, you would have visible physical injuries. And we know that's not true. So strangulation is not choking. Choking is like choking on a carrot or a hot dog. It's internal. Strangulation, the mechanism is pressure on the neck, and it's external. Strangulation is very serious. You can die from this, or years later, you can stroke out. And typically, 50% of all strangulation patients will not have any visible physical injury. So that makes this difficult in order to get by those barriers. Next slide. So if we go back to the literature to 2001, some of the pioneers in this field were Gail Strack, Dr. George McLean, Dr. Dean Hawley, who looked at 300 attempted strangulation cases out of San Diego. So 2 young ladies were murdered, and they were tasked with looking at what might we have done as a community to improve things and have prevented these girls from being murdered. So she pulled 300 cases out of the police files, and what she found out was that 50% had no visible injuries, and 35% had injuries too minor to photograph. So maybe a little redness, maybe a small abrasion. When we talk about visible injuries, those are different than symptoms that they might have. So today, if we did this study, I think that the issue, it would be higher than 50%, because a lot of forensic nurses have been trained in the signs and symptoms. So if we heard a voice that crackled, if they had difficulty swallowing, if you gave them a popsicle, could they swallow easily without constantly gulping? Are they constantly swallowing or saying their throat is sore? Does it hurt? We won't know if it hurts unless we touch. So different things like that. Anyway, next slide, Sarah. So the vital neck structures are the arteries, the carotid artery, and the jugular vein. So they're listed on this slide as number 1 and number 2. The carotid is the red. You can see the arrows pointing up. So the oxygenated red blood is going up to our brain, and our brain loves it. It has to be bathed in a continuous flow of rich oxygenated blood in order to function. The jugular is the blue blood coming down, and that's the blood that needs to be reoxygenated, and it goes to the heart, and again, the oxygen comes in and it recirculates again. So those are the 2 structures we're very concerned about. The third structure, number 3 at the top, is the hyoid bone. And this is the only self-articulating bone in our body. And this helps support the tongue, and it's the jaw. So it's difficult to fracture this bone. And so those typically are the 3 structures we get worried about. The thyroid cartilage, number 4. If you were to stomp on someone's neck with the good old boot stomp, that would be 33 pounds of pressure that you could fracture that cartilage there. All right, next slide.
Sorry, one moment. Okay.
So with strangulation, these are the 2 pressures we get concerned about. And you can see here the carotid artery occlusion takes 11 pounds of pressure, and quite a few of you wrote 4.5 pounds of pressure, which is the jugular vein occlusion. So you all can put your hand up to your neck, and the carotid artery is the anterior neck, and it takes more pressure to occlude this because there's some muscle over that artery, which is a good thing. We want to protect that artery because if it's cut, like you can, or if you've ever seen it, you cut that artery and blood's going to spurt out and you will die very quickly. The jugular is more lateral on your neck, so it doesn't take as much pressure, only 4.4 pounds of pressure. And you can see this is done very quickly within 10 seconds. So by the time we can count to 10, you're going to be passing out. Next slide. The tracheal occlusion, that's that 33 pounds of pressure where you can fracture the tracheal cartilage, and that definitely requires more pressure. Next slide. So these are just some examples of applied pressure. You can see if you had a handgun and were pulling the trigger, it only takes 6 psi. PSI means pounds per square inch. Look at opening a soda can. Takes more pressure than it does to strangle, whether it's the carotid or the jugular. And of course, handshakes take much more pressure. And that comes from Dr. Bill Schmock out of the Metro PD in Louisville, Kentucky. So this apparatus in the photographs is a hand grip that you would find OT using in your rehab department to show strength. Next slide. So how long does it take for loss of consciousness? And you can see on this graph, and I want to give a shout out to the Strangulation Institute for all their work in the strangulation area. This is one of the graphs that Dr. Schmock put together based off some research that we base the applied pressures from. So we can see here from 0 seconds to 152 seconds. So 0 seconds, we apply the pressure, and we're going to lose consciousness in 6 to 10 seconds. Okay. We'll have a little seizure at 14 seconds, loss of bladder control, 15 seconds, in 30 seconds, loss of bowel control, and then pretty much at 1 minute, you stop breathing. So this can go very, very quickly. And that's the danger point here. And how fast can you come back? So if you add alcohol, if you have drugs, those are other factors on top of this, and then you're strangled, it's going to be a little bit more difficult. Next slide, please. So what about obstacles you and your emergency rooms face in identifying abuse? I just jotted some things down here for you to kind of think about. Oftentimes the staff is not trained to identify abuse as a cause of injury. They just can't think it, therefore they won't go there. They're primarily concerned about treating the injury or the complaint versus other things that might have to do with the violence. Patients lack privacy, and so they're not as forthcoming in their history. So they don't always give you everything the first time you ask. There's a lack of resources to assist victims. You may not have a social worker who's been trained in this in your emergency room. You may not have an advocate to respond to help you with resources such as shelters or even a restraining order if that would be needed. There's belief that the abuse is of a private family issue. Some people still believe that and hold it very tight. Identifying the supporting agencies is very time consuming. We all know that who work in this field. Just trying to find a shelter sometimes if someone has some alcohol or drugs on board is almost impossible. And then there's the fear or the implications of mandated reporting. If I make this report and what's he going to do to her? What's he going to do to me? Is he going to come after me? So these obviously are obstacles that we have that face us. Some of them may apply to you or none of them may apply to you. Next slide. The other consideration is the lethality assessment that we need to think about with these patients. And that's going to require a little bit more documentation from you. Because strangulation has such high risk associated to the lethality, we know this from Dr. Jackie Campbell's work. We know that if they have been strangled and they're in a domestic violence situation, the lethality will increase 700 to 800%, meaning that the next time they're going to be dead. So it is extremely lethal. And strangulation is one of the most intimate ways to harm her. And this is an act of violence against females. For the most part, men are also strangled. But for the most part, we see females coming in as victims. Hands are the weapon, and they're very easy because they're right there on your body. And it's very easy to use strangulation as a method of power and control because she knows the next time could be the last time. So we will have lethality screening handouts for you that are available in the follow-up following this webinar. Sarah will make sure that that happens. Next slide.
Sorry, 1 second. When I answer your question, then it takes me off that thing. Okay, here we go.
Okay, so let's start a little bit from the beginning. A case report comes in to the emergency room. She's triaged in with pain on her neck. She reports strangulation by her ex-boyfriend earlier today. He put his hands on my neck 4 times and I could barely breathe. My throat hurts and I have all these marks on my face now. I do not know what to do, so I came to the hospital. So the first step here after the nurse takes this triage in is there has to be a consideration about is this mandated reporting or is it non-reporting? She can come in and tell you that, that's great. But if it's non-mandated reporting, then you're going to have to ask her if she wants police involved. So there is a link here with some codes that should take you to laws. You can look for your state. I did put the Georgia code in here since I'm living in Georgia. But if you go to the Strangulation Institute, they have a state map there and you can look and see. The other issue here is that laws have changed very much so over the past 5 to 6 years. There are currently only 2 states that haven't had changes to their strangulation laws, and that would be Ohio and South Carolina. Most states are now calling this a felony. So the game is up here, and prosecution is looking for better evidence. And so one of the ways that forensic nurses can help with this is excellent documentation. So she agrees to have the exam and she agrees to notify the police. Next slide, please. So this exam is one exam with dual purposes. There's a medical component to this and there's a forensic component to this because we're really going to focus on the documentation of the injuries as part of our forensic piece. So the medical piece is a pretty big issue here. And we're going to go to the next slide. Okay, so oftentimes clinics are freestanding facilities, or you may have a program that's at an advocacy agency, or it's just a freestanding center. If you have victims who come in that you're seeing for sexual assault who are strangled, and they have any signs and symptoms, they need to go to the emergency room for further medical testing and evaluation. So that's why the red light is flashing on this, just so you understand that. Next slide, please. So if the patient reports an inability to swallow, loss of consciousness, I was standing one moment and the next minute I'm on the ground, there's incontinence, or you can see that they're having difficulty breathing with stridor, subcutaneous emphysema, any voice changes. And I always ask the patient that, how does your voice sound to you? You're suspicious of a hypoxic brain injury, and typically in strangulation, they do have hypoxic brain injuries. You've taken their oxygen away. They have dyspnea, they're having trouble swallowing, or there's significant bruises or tenderness of the neck and surrounding areas. Next slide. So these patients need to be transferred to the emergency department for a referral of a CTA scanning of the soft tissues and vascular structure of the neck as appropriate. That needs a physician to order that, or you have standing orders in your emergency room that you follow. Not all patients are going to agree to this. Documentation is key if you're in a freestanding or clinic center. They should not be discharged without detailed instructions, and certainly they need to be accompanied by someone who is responsible. Consider calling your emergency medical services, and then they can refuse at that point. That should be a discussion at your multidisciplinary team. I always tell when I used to do roll call with law enforcement, don't put that monkey on your back. Why are you doing that? Why are you trying to make a medical decision here? Let EMS take care of this. They can refuse EMS, that's totally fine. Not only does EMS document that, but there may be a call into the radio room where they're discussing this with the radio room nurse and physician. Once that call comes in, that's all documented and available as evidence for the case or that prosecution. And not everybody knows that. Next slide, please. So let's hear from Dr. Bill Schmock on the CTA. This is a short little YouTube, and I think it's pretty important.
Oops.
Did we lose the audio? Sarah, we can't hear it.
Okay, I'm not sure that we'll be able to hear it. I'm hearing it. So what I'll do is I'll make sure to share this now.
Okay.
I'll share the when we get to the end of the webinar, I'll share the link.
Okay.
Okay.
So we're having trouble with the audio on that, folks. So Sarah's going to share the link. This is a very short little YouTube. It's 3.5 minutes, and Dr. Schmock goes into the reasons that it's very possible that your strangulation victim could have a carotid dissection, and that's what we want to look at. Okay, next slide.
1 second, I'm just getting that to everyone now. Okay. But pay attention now, don't look at it now. Okay. All right. There we go.
Okay. So at the Strangulation Institute, there's a group of advisors for the Institute, and Many of them are physicians who worked on the medical radiographic imaging recommendations. So you can download this from their site under their resources. You have been given the link in this PowerPoint. So it takes you down the pathway, very easy that your ER doctors, your nurse practitioners will understand what they need to do with this. And pretty much it's a CTA of the neck. So next slide. One of the new things that they added this year in 2019 was if there is a delay in getting the CTA for whatever reason, maybe the machine is down and they can't get to it until the morning, you should go ahead and consider giving them an aspirin. So again, that is a medical decision that your team is going to have to make. And these are in general guidelines that you should follow. Now, I'm sure you're all thinking, oh my goodness, out of all those strangulation patients, how many really have carotid dissections? So we're going to go to the next slide, please. Okay, two things. So this is, I just have to write down, I have to come back to the radiologic. I'm going to talk about that right now. So there's a new study that came out this past year from a group of radiologists out of Kentucky that had a number of strangled patients that they did a CTA of. So they looked at their clinical signs and symptoms. They looked at the CTAs and how many of those, out of how many had suspicions for carotid dissection. So the number was low, but their conclusion was just based on the signs and symptoms, there is no way to know. So we should still continue moving forward with the CTAs. So they supported that, and that was a nice research that they put out on that. The other thing that I want you to think about is all of you that work emergency rooms, that have your stroke patients come in, whether you have door to dock with them, whatever it is that you're doing. One of the questions we never ask them about their past is if they had been strangled. And I don't know how to approach that. If any of you have any ideas or connection with the stroke people, that would be great, because we know that probably if you're seeing patients come in with strokes under the age of 45, probably had a carotid artery dissections earlier, or an injury to their carotid due to strangulation. And we know that this can happen years later. And the original cause is the strangulation. You know, I always remember, you know, anytime there's an injury to any tissue, it is never as good as it once was. So if you kind of remember that, this will help make sense to you. Next slide. All right, pediatric strangulation, just a little bit about that. Not everything is black and white with pediatrics. Next slide. So we don't know the amount of pressure for vessel occlusion in pediatric strangulation. We suspect that it's probably less pressure, but no one knows that. How could we ever study this? We can't. So we really need to have good eyes, listening skills, and hearing skills combined when we are looking at these kids. Oftentimes they don't report. How could they? How do they know? What do they know? They don't. So it's up to us as a society, when we see bruising on the face, the neckline with scratches or petechial hemorrhages in the eyes, that we say, how did that happen? Tell me what happened. I know a lot of the PEDS cases I would get in came in because of the teachers in schools. They were picking up on this and reporting it. CPS went out. CPS has been trained in strangulation, and that ticked something with them, and they brought them in for their exam. So just another thought for you as you think about teams that you want to put together here. Next slide, please. So again, there's a lot of anatomy difference between the adult and pediatric. Very simply, the adult's windpipe is straighter and wider, where the child is smaller and narrower. And you can see where they can get into trouble down here with the narrower windpipe because mucus will accumulate and their airway is just going to get plugged up. So they're really going to have a hard time breathing. Next slide. Their tongue is larger, they have decreased muscle tone, the size of their oral cavity, so it will obstruct easier. Their head is larger, their forehead is large relative to their body size. Their neck is weaker, so they're more susceptible to the flexion. And then again, obstructing the airway when lying in the supine position, just their whole anatomy is smaller. Next slide. This was a case, just real quickly, the bruises were noted by the grandmother when the child was dropped off for babysitting. CPS was called. You can see that there's bruises on the left side of the face here, but it's very difficult to see the scratch marks under the chin on the neck area here. And that's what the negative inverted filter is trying to point out. So CPS was suspicious about this, and they called and brought the child in for a forensic exam. Next slide, please. So the medical recommendations aren't there yet for peds. I know that there's a group looking at that, but we don't have consensus yet from all the child abuse pediatricians. But what we do have consensus on is that if you do have these kids pretty much up to age 5 and you're thinking potential strangulation, again, you should be doing a skeletal survey for occult fractures in these kids because if they're being strangled, they're being abused some other way as well. So there's just limited research, very limited for peds, and usually consists of just case studies, often involving a fatality. Next slide. Okay, going back to our patient, she arrived at the hospital. She was triaged. We figured out the reporting. The forensic nurse was called. If you don't have a forensic nurse available, how is your ER staff going to handle this? Have they had training? Do they know what to do? We're lucky because here the forensic nurse arrives. Next slide. Step 1, greet your patient, introduce yourself, let them ask questions, talk about the procedures and the consent. You're going to get written and verbal consent for the exams and for the photographs you will need to take, and discuss with the patient where this information is going to be stored. It's sensitive information, and oftentimes that's a concern for the patient. Next slide. So always start at the top and some things that you're going to do to comfort the patient. So you're going to need probably to do some basic neck photographs and face before evidence gathering. Then get your swabs, which should be a buccal, bilateral neck, and fingernails are the basic, pretty much the basic. Perioral, if indicated, and then some comfort measures for her or him. Some drinks, I always offer ice chips just to see how they're going to swallow, and then often just an ice pack that they can hold on their neck. You can observe for that, again, swallowing whether they're in pain or they're starting to cough a lot. Once the patient is comfortable, we can start with the history of the event. It will be easier to obtain. Next. So we're going to have to get some medical history and then the event history. Tell me what happened. And then what form are you going to use for this documentation? That's a decision you and your team will have to make. Oftentimes patients do not know the word strangulation. They may call it choking, but many times they don't even recognize these words. One of the things I learned from the group in San Diego was that if they said, "Did anything touch your neck or face?" they got better response than using choking or strangulation. Next slide. So step 4 is your examination head to toe. We're going to do a 360 around the neck. Next slide. Then you got your vital signs, level of consciousness, all of your face, eyes, ears, nose, stridor, oral exam. That means checking in the mouth. If you don't look, you ain't gonna see any tender areas and pain. So oftentimes you will say, "Where do you hurt?" "I don't." And then you touch the neck and they pull away and go, "Ouch." So 2 different things here that we need to talk about. Next slide. Pain documentation is really important, and every patient should have this, whether it's a child or an adult. It's your pain scale, whatever that is, 5/10 or happy face. Please make sure you get that on your document. Step 4 is that physical assessment, and we're looking at the neuro stuff. So that's really, really important. Most of your forms, what we do with that as medical providers is we document the exception. And often what prosecutors don't know is that you did do a neuro exam. So if you can put that somewhere in your documentation, that would be great. I did give you a link here to the cranial nerve assessment. It takes about 10 minutes. You'll love it. So please incorporate that into your exam. Next slide, please. This is more the swabbing, and there's a lot of biting with strangulation. So you probably need to be prepared to swab those bite marks. And don't forget to use your ALS light with this as well. Next slide. Documentation. And we're going to go through this real quickly. Go ahead. So this form Sarah will have for you after the webinar. So this is the non-fatal strangulation photography protocol. Next slide. So we're doing that 360 around the neck. And the big thing here is look behind the ears. You're going to see a lot of injury here. They're yanking on the ears. There's scratch marks, there's bruises, and there's bleeding. Next slide. So again, the front of the neck, with and without a scale, the side of the neck, get a really good visualization. Next slide. So again, depicting that 360 around the neck and the ear. One of the biggest things is to get that hair off the neck. A lot of people have long hair. You're going to have a hard time doing a really good visual assessment of that neck if you don't get it pulled up on top of their head. Next. So again, don't forget to look at the scalp. A lot of petechial hemorrhages can happen there. Next. The eye positions, 9 different gazes. Look up, look down, look to the right, look to the left. Keep going, Sarah. Next. This is the important one, is to be sure you lift the eyelid up and you lift the eyelid down. It's great if we can see petechial hemorrhages on the sclera, but a lot of times we can't, and it's on that capillary bed in the inside of the upper or lower eyelid. You can use a Q-tip to help you, or you may have to do it. Next. Don't forget the mouth. So looking at the lips, have them open up the mouth, check the frenulums under the lip, above the lip, and then under the tongue, and then looking at the soft back palate for any petechial hemorrhages or injuries. Next. And most of all, don't forget the hands. Oh, I know I stand on this. So oftentimes we don't know what the length of the fingernail is. Did she have any fingernails where she could have scratched him? Did she have any fingernails where she was scratching herself? Don't know if you don't take a picture. Next. And then we want to measure the neck. You can see up in the corner, there's a little marker there where we've indicated where to put the paper tape. So here we have 13 inches on this neck. We're going to document that by a photograph and in our paper charting. And then you're going to give the patient the paper tape and they can measure their own neck at home and call it into your program's voicemail if that's what you would like. Next. Then the following, you want to ask them to show you how the hand was on the neck. In this case that we talked about, she was strangled 4 times. So we should see 4 different pictures here. This just depicts a styrofoam head, 1 hand, carotid hole, and then 2 hands. Next. When I give patients the styrofoam head, they get kind of angst about it and don't know what to do with it. So we developed this trauma-informed care, photographing the strangulation patient. This is the last page on that document. Pull it off. You got to print it off in color. Pull this page off, put it in plastic, and have your patient point to 1, 2, 3, 4, 5, 6, 7, 8. Take a picture. So you've got this on a clipboard. She's just pointing. Don't cover the number, but just point, and you can take a picture and you get 4 strangulations here. Very easy, and they tolerate this feather. That has been my experience. Next. So again, this is the photo documentation, and we're doing a 360 around. Next. Okay. This is the 360. Don't forget, you're going to have to write this on your traumograms as well. Next. And this is the body map and assessment. You can see here, just as an example, this person had a lot of injury with this assault. Next. Oftentimes there is sexual assault associated with the strangulation event. Sometimes not, it's just a strangulation event. So I don't know your programs and what your data or statistics are. Every program seems to be a little different on this. So when you have one, you should consider the other, or at least ask the question. Next. This is the last part of it. It's a case review. This is a 26-year-old patient. It's a Sunday. She's in the shower. She's getting ready to go to work. The ex gets in through a window, goes into the bathroom, grabs her by the neck, pulls her out of the shower. She doesn't resist because she knows what's going to happen. And she cooperates in order to get done. When he's finished, he goes and gets their son from upstairs. They go in her car over to his mother because she babysits. The mother babysits the grandchild. So she goes outside, he follows her out, he gets argumentative with her. Again, the brother comes out and pulls him off of her, and she calls the police a couple blocks away, and she comes to the hospital. So she comes in originally as a sexual assault. Next slide. So you can see here, it's a picture. You can see there's a couple bruises on her neck. The middle one is a suck mark. The other are bruises from the strangulation. Next. So again, get your ruler in there. She's helping me. This is in the plane at a 90-degree angle. And we can see bruise number 1 is probably 2 by 4 centimeters. Next slide. You can see she says he put his finger behind my ear. He has a large hand and has done this before. Clearly you can see that fingertip bruise there. Next slide. And you can see them all the way down her neck. Next slide. And this is the side-by-side with the negative inverted filter. You can see that that highlights, you're able to see the bruises easier. Next slide. So the outcome was the case was dropped. She wouldn't pursue legal charges and stated, I made it up as I was mad at him. So points to improve the outcome and care. Do you have advocates who would respond, someone to support her through this exam? Did you ask for a restraining order from law enforcement? Did you talk about safety planning on discharge? And probably one of the biggest barriers for us is the cell phone. They're always on the cell phone. Someone is always texting them, you need to come home, you need to come home, you need to do this. And then they start turning off, and you know that you've lost them because they're going to respond to the cell phone and take off. So again, who is there to support her or him? Next slide. These are some resources from the Strangulation Institute. Signs and symptoms are really clear. You can download these for yourself, your PowerPoint, in your institution. Next. Discharge instructions specifically for pediatrics. Feel free to use. Next. And how do you take action in your community? All right, next. So, do you have documentation forms for this? Do you have a photography protocol? Do you have medical guidelines that your emergency room agrees to or standing orders? And do you have discharge planning and the ability to call an advocate in? So these are some things you need to think about if you're going to try to start this team up. Next. So again, we're at the end of this webinar. Remember, this is a bird's eye view of the topic. So continue your education, visit the Strangulation Institute for more information, and work with your MDT to affect change in your community. These are the key points that I wish to leave with you. Next. Okay, we've got some references here for you as well. Next. And I do want to give a shout out to the Academy of Forensic Nursing and our partners in Violence Against Women International and the Strangulation Institute. Next. I'll very quickly tell you that the Academy of Forensic Nursing is going on a cruise, and it's going to be March 20th through the 23rd out of Miami, and it is on child abuse. So I hope to see you there. If you have any questions, please contact me or get a hold of Sarah and she'll send me something. All right, thank you so much. Sarah.
Thank you, Diana. We actually have quite a few questions out there, so we'll try to do our best to get to all of them in the last few minutes that we have. If you could put those questions under the question and answer tab instead of the chat, that way if I don't get to it or we're not able to answer your question, we'll be able to follow up afterwards to answer anything that you might have. I do want to tell you quickly about the EVA system for sexual assault examinations. It's a portable, reliable video colposcope and digital camera that enables full body and external body cavity images, as well as video capture for forensic documentation. The simplicity of the EVA system allows you to focus more on your patient and less on equipment, with high quality images and videos, filters with saved unfiltered copies to highlight redness and bruising. Our HIPAA compliant platform allows for easy yet secure sharing of documentation with law enforcement that ensures the chain of custody. And what's really exciting about the EVA system as well is that we also have capabilities for teleconsultation, which is great for learning and getting expert advice from your peers in the field when you need it. If you're interested in learning more about the EVA system, we'll be happy to schedule a demo for you, which we will send out when I send up a follow-up email in the coming days with all of the other information and recording of the webinar. Okay. Great. So getting to those questions, I did have one question for Diana that I thought was important, and that would be, how do you document ligature marks? You know, anything that if a victim was like strangled with something other than hands, like a cord or a belt, and should you ask the victim if they still have access to the item that was used to strangle her?
Sure, those are important things to document. So you would again do the 360 pictures around the neck. Make sure that you get your ruler in there. Again, that's based on history. We never know what is really used in the strangulation. So we rely on our history that we get from the patient. And we would want to know where that item was. And if she had told the police or the sheriff about that. If not, we would communicate that to law enforcement, as that is evidence that they would need to go out to the house and pick up. Because oftentimes there's a pattern that you could see on the skin relating to the implement or ligature that was used.
Okay, great. Linda had a question about what the reference is for the timeline regarding the LOC and symptoms. I think this was regarding the timeline of like how long it would take for somebody to like lose consciousness and
Yes.
or to die. Yeah.
Yes. That comes out of a study. Okay, can we go back to the references for just a minute? Can you go up? Let me just look here real quick. It's an older study out of the 1950s, and it happened to be prisoners that were, or men that were prisoners for a long time. There were 500 documented strangulations. The device was placed on their neck, and they were able to measure the pressure. That's how we know what the pressure was. So they had like 500 case examples documented. And it was back in the 1940s. How you can imagine that we couldn't do that today with our IRBs. And I don't
No, that's quite shocking, actually. Okay. Our next question is from Deborah. For freestanding centers, what is the time frame from the event to the time of the exam that we need to send the patient to the emergency room for CTA scanning? She's had a few patients that it has been remote from the event and is unsure about how long from the event she needs to have them evaluated.
Sure. If they're coming in, and typically we just use the 5-day rule at this point until we get more information. So if the overall rule for evidence collection is 5 days in your community, go with that. We can still pick up information at 5 days. Remember that today DNA is easier to obtain, as the DNA forensics is way, way, way more sensitive. So use whatever you're doing for the sexual assault, and understand if the patient comes in maybe 2 weeks later and says that I was strangled, then the next day they could go in and get the CTA. Yes, absolutely. Is it emergency right now? No, but they still need to get that. And we do have a couple cases that are out about 8 days who came in with fractured larynx and didn't know that they had that. So you just never, ever know. If you're still unsure, contact your physician who is a consultant to your program and talk about that with your MDT, because these are the outliers a lot of times that we get worried about.
Okay, our next question comes from Mary. When a forensic nurse was on the witness stand about a strangulation case, the defense attorney would not hear of letting the forensic nurse be certified as an expert in strangulation because there's no credentials that make her certified or an expert in the area, even though this nurse has been doing strangulation assessments for 8 years. How would you handle that? Is this more of just for the judge to decide, or?
That's, use the word BS.
Right, okay. I understand.
We're always at the hands of the courtroom, Mary, whether we're an expert or whether we're a fact witness. That's not a decision that we get to make, and I would have hoped that your prosecutor would have spoke up and talked about your education, training, and experience. Okay, the credentials, the certification credentials don't make you. It is your experience, education, and training. And that's just a learning step, probably for you in your county, that you have to have some serious discussion about that. The other piece of advice I give to you when you're looking at your resume is that this is the strangest thing, but I have been told by a prosecutor that they were told that people look to see if you're an expert by how many times you document the word strangulation in your resume. So every training that you take that has strangulation in it, write it down on your resume. Strangulation training, sexual assault training with strangulation training. Okay, that's another little tip that I learned.
That's a great tip. One is we just have a comment from Larissa that if you're a member of the AFN, Diana is a phenomenal resource. And she's someone that's in Georgia, so she's seen you speak on the topic.
Oh, good. Thank you.
Yes, we have a lot of people from Georgia, I believe. Stephanie asks, what do you think of all the children that are playing the choking game and having strokes at a younger age?
Yeah, that's a hard one. Two things here. I would hope that the teachers in the school are talking about this with the kids, and there's a conversation within the family about this as well, as how dangerous this is. There's a group of them that are playing the choking game, and then because of the high they feel with this, they'll practice this with ligatures at home when they're having a bad day. And the ligature fails to release and they die, and the parent goes in and finds their child oftentimes like this. Some of the medical complaints that they'll see if the pediatricians don't understand this are red eyes, a little bit hazy, not really with it, and complaints of headaches. So just different things like that. I'm always quite amazed when I see the sexual assault adolescents come in. And I had one about 2 months ago who told me that when I asked her about, did anyone put anything on your neck or around your mouth, she looked at me and she goes, well, she said, he really wasn't into it. So that was okay with her. But we had a very serious talk about how dangerous this is. We only have so many brain cells, and the brain cells don't regenerate. So every time you're strangled, you're killing your brain cells. Bottom line, I don't know how to make that any more concrete.
We have a question from Angela, and then we have a few questions from Anna that I want to see if we can answer. I know we're running out of time. Why do we measure the neck if the swelling occurs on the inside of the neck?
Because there will also be swelling on the external side of the neck. You'll see an inch or two, okay, because it all pushes out. I have, in my career, I've not seen a lot of external swelling. It just isn't there. The other thing with this, it's just a nice nursing thing that we can do for them. Sometimes it makes them feel a little better to be able to look at that the next day and go, wow, it's the same. I'm okay.
Okay, great.
There's no hard medical documentation that says that we need to do this on everyone. It was just part of the nursing protocol that we put it in.
So both Anna and Lori have a question about how you would evaluate strangulation on the skin of a darker skinned victim.
Yes, that's hard because there's a health disparity with that race and all dark-colored victims. So if we can't see the bruise, number one, maybe we can feel it. We can see swelling. They pull away when it's touched. So we would use an ALS light to see if we could see anything. And all we can do is just document what we see and feel. It's very difficult.
Is there something about fluorescent dye? Anna had a couple questions about it, but I'm not sure if I'm understanding her question correctly.
The time you could use dye would be if there was an open area on the skin. So if there was an abrasion, yes, you could put the dye on that and it would uptake. But the dye, if there's no abrasion or no opening on that skin, won't uptake.
Okay, great. Those are all the questions that we have for today. There are a few other questions, mostly about like getting access to the slides, and like I mentioned, we'll give out handouts and a recording of the webinar within a couple of days. We'll send everything out to you. And you have Diana's email, if you can still see it on your screen, if you have any direct questions for her. If you have any direct questions for us, we're happy to answer them. I want to thank you. I want to thank everyone for attending. We hope you got the most out of this event, and we'd love to receive ideas on future webinar topics. We are not CNE accredited, but we can provide a certificate of attendance. You'll receive further instructions on how to get a certificate in our post-webinar follow-up email. Again, we'll have the links to the handouts and a link to the webinar recording. Once again, thank you so much to Diana for giving us all of her expertise on this topic and many others, and we hope to see you at the next webinar. Thank you.